Post-traumatic seizures and post-traumatic epilepsy remain enigmas shrouded in mystery. This presentation proffers a simplified hypothesis. Fits after brain trauma have been temporarily stratified into immediate seizures, that is within 24 hours, early seizures from 1 to 7 days, and delayed post-traumatic seizures, which concord with post-traumatic epilepsy. Immediate seizures correlate with the excitotoxic surge which occurs after brain trauma. The spillover of neurochemicals results in mass activation of neurons. Early postoperative seizures occur between day 1 and day 7. The putative mechanism is a lateral spread of impulses. The cause of this lateral spread is a failure of inhibitory interneurons. Inhibitory interneurons are normally interposed between activity neurons. Inhibitory interneurons fail because of a metabolic shutdown consequent to traumatic brain injury. Post-traumatic seizures occur in later phases of traumatic brain injury when the brain tries to repair itself. Brain repair aims to restore brain function. There are many ways in which functional restoration occurs. In the early phase, neurons which have shut down may restart if they are viable. Axonal conduction, which has been stopped, gets restored as the damaged microskeleton of the axon is reorganized. In later phases, neuronal rewiring occurs. This is an attempt to bypass irreversibly damaged axons and to connect to functional neuronal islands. This neosynaptogenesis may result in aberrant circuits which beget seizures. Seizure circuits form. Neurogenesis, which occurs in the dentate gyrus and in the periventricular zones, along with the aberrant neosynaptogenesis, result in abnormal seizure circuits and post-traumatic epilepsy. The role of prophylactic anticonvulsants is contentious. Anti-epileptics suppress seizures, but they do not prevent post-traumatic epilepsy. The Brain Trauma Foundation recommends that prophylactic anti-epileptics be administered to victims of severe traumatic brain injury for a period of 7 days. In practice, however, prophylactic anti-epileptics are administered routinely to most TBI victims for variable periods of time. There are many reasons and justifications for this practice. The incidence of overt seizures after brain injury varies from 3% to 50% in different types of head injury. Depressed fractures with cortical contusions are associated with a very high incidence of seizures. There is a high incidence of non-convulsive or subclinical seizure activity in brain injury and bleeds. Subclinical seizure activity is associated with compromise of neuronal function and neuronal integrity. Seizures beget further seizures. Seizure circuits may be reinforced with recurrent seizure activity. And seizure activity is not benign. A seizure increases the cerebral metabolic demand for oxygen. This will aggravate neuronal insult when the intracranial pressure is high and when the cerebrovascular reactivity or autoregulation is impaired. Antiepileptics have relatively limited toxicity over the short period. If a patient with a traumatic brain injury has not had a seizure, anti-seizure medication can be stopped when the brain swelling subsides and when cerebral oxygenation is regulated. The decision has to be made clinical. However, glial scars and resorbing clots may be focal points of seizure production. If a patient has suffered post-traumatic seizures, especially of the delayed variety, stopping of anti-epileptic drugs will be associated with a risk of recurrence of seizure.